Hadassah On Call, New Frontiers in Medicine. I'm your host, Mayan Hoffman. It's scorching outside. July in Israel brings temperatures of between 80 and 90 degrees Fahrenheit, and in some areas, it's sticky and humid. All I can think about is escaping to the beach instead of heading to the office. But the silver lining is the sunshine, which allows us to spend lots of time outdoors, soaking up vitamin D and staying active. Currently, I'm training for a marathon, so I wake up really early in the morning to run and beat the heat. I usually cover between 10 and 20 kilometers, but on weekends, my long runs stretch to 25 or 30 kilometers, which means being outside for over 2 hours. I feel great, and as we've consistently learned from our Hadassah podcasts, good nutrition and regular exercise are essential for maintaining health in many aspects of our lives. Today, we'll discuss the vital work of Hadassah's Allergy and Clinical Immunology Unit, which provides consultations, diagnoses, and treatments for a wide range of immunological diseases. We'll delve into some of the latest treatment advances, including groundbreaking research on lupus antibodies. Joining us for this conversation is Dr. Yuval Tal, Director of the Allergy and Clinical Immunology Unit at Hadassah Medical Organization. Welcome, Dr. Tal.
Thank you.
So I want to start with a broad question. If you can describe the typical range of autoimmune and allergic disorders that your unit treats and how some of these conditions impact patients' lives.
Wow, this is a huge one. In the university, they call it allergy, asthma, and clinical immunology. This is like calling a surgeon that makes surgery on fingers. I'm an expert on finger surgery, and I also operate on this one. So allergy is like one arm of the immune system. Asthma is sub-arm of the immune system. So the profession is clinical immunology. It's combined of three distinct issues: autoimmunity, immune deficiency, innate or acquired. And the third one, which is the biggest one, is allergy, which is the world. We are also doing basic and clinical research. Actually, we are the only department in Israel that combine every aspect of immunology available to medicine.
It's incredible. I didn't even know that that's such a wide department.
Yes, we are a very big department. For instance, we have like 70 clinical immunologists below 70 years old in Israel, maybe 75. Hadassah has 12. We are huge.
It's huge.
They are great doctors, each and every one of them.
So what are some of the latest advancements or treatments in clinical immunology that have significantly improved patient outcomes?
Where the future is biological treatment, which is a precise medicine. This is our novelty and this is our power. We can block a distinct protein of the immune system far before it impacts any tissue, which means if you close your eyes and imagine the immune system, I know that if I'll block it here, I'll avoid the reaction here. So I'll try and give you an example, a simple one. There is a disease or manifestation that called oncologic related pruritus, which is a devastating pruritus, which means if you have a scale from 1 to 10, it's 10.
Wow. I
cannot live with this pruritus. So they sent us the first patients a few years back. Professor Lotte from Oncology department, she said, you must help her. So I immediately rose up because I was got panicked. I asked her, please write that she has atopic dermatitis. She said, but she don't have atopic dermatitis. Atopic dermatitis, which is a skin manifestation of allergy, very common. Skin asthma. So I told her, please write it down, and if it will work, I will explain. So she wrote it down, and the lady came to me, and she said what every patient we recruit so far for this research said. I'd rather die from the cancer so it will stop itching. I said, that's it. This is, I can't stand by. So we called it atopic dermatitis. And we gave her a significant specified medication against atopic dermatitis, which is called dupilumab. Dupilumab blocks protein interleukin 4 and 13, doesn't matter the name. Protein number 4, for instance. But After protein 4 and 13 elevate in the blood, they produce protein that's called interleukin 31, which is the itch cytokine. So if the patient didn't respond to steroids and to phototherapy and to antihistamine, this is what we have left, cytokines, protein of the immune system. So I said to myself, if we'll block 4 and 13, eventually 31 will not appear. The mechanism is far more complex because now we know it clearly. After the third shot, she was cleared of pruritus.
Oh my
Now,
goodness.
This is not the highlight.
Okay.
We already concluded 13 cancer patients in this study. 2 of them, one which I distinctly remember, came to us with a flight ticket to Switzerland for euthanasia because of the pruritus, because the cancer was stable. He wanted to die, and he had flight ticket already available in his pocket. After the third injection, he was clear. He tore the flight ticket in front of us. So now we have 13 patients and we have almost 100% success because one of them was wrongly diagnosed. He has a different kind of rash. It took us a while because he needed to come to us, but we have almost 100% of success in treating pruritus cancer because of target biological medication. This is the future.
Is that only at Hadassah or is that at other places?
Actually, we were the first to publish it in the world in a journal that's called JACI Global, which is a journal of allergy and clinical immunology, which is the biggest journal of the Quadra AI, the American Association. And it's a daughter journal. And now we have a very big research concluded. We will probably have 20 patients. And we will write down the mechanism, and we know the mechanism like pretty well. And we will publish it. It could help tens of thousands worldwide.
Amazing. So, what are protective antibodies, and how might they help in treating immune-mediated diseases?
Okay, our strongest arm is utilizing biologics.
Okay. And that's also when we talk about protective antibodies?
Yes.
Uh-huh.
The biologics target distinct protein or cytokine or surface protein on cells.
Okay.
Which means if you target interleukin 5 receptor, which is a receptor on the cell surface, by antibody called Benralizumab, you immediately kill all eosinophils in the body on the same day. I'll give you an instance. We are leading an investigator-initiated research about using Benralizumab for eosinophilic disease that doesn't have any treatment. I came to the US and talked to the general medical immunologist medical of AstraZeneca. So he asked me, why should I give it to you? Because we wanted like for 20 patients, which is roughly 2.5 million shekel, just the medication.
And you were asking for it for free for the trial?
Yes, and another 500,000 for the research itself. I said, I'll tell you why. Just think along how long will it take you to do what I'm going to say. We had a 45-year-old patient, male patient, with a rare disease that's called eosinophilic cystitis, which means the entire urinary bladder is full with cells called eosinophils, and you cannot pass urine, and you have bilateral nephrostomes, and it's drained the urine from your kidneys. And the only solution in medicine so far was radical cystectomy, complete chopping of the bladder, and the ileal conduit, which you take a part of the intestine and do a replacement pouch for urine, and then you catheterize it until you have like septic shock and die. And he was a healthy 45 young person. So he came to Hadassah for second opinion, and they told him, we have a wonderful solution for you, radical cystectomy and ileal conduit.
Oh.
And a young urologist got up and told me, just a minute, I know Yuval has a solution. So he called me. He said, you had a solution. I told him, no, it couldn't be me. I'm a biologist. I always say, maybe I have an idea. Perhaps we'll try. No, you were running from internal medicine to the unit, and I screamed, I have a 6-year-old child in Russia which of cystitis. What will I do? And you said, bring him over, we'll fix it. And we went, okay, this is sound more like me. Okay, so I sent one of my children, my amazing doctors. I told him, please, Aviv, go down and see that this is real eosinophilic cystitis and not leukemia or parasitic infection or whatever. So he came back and said, yes, it's eosinophilic cystitis and it's non-treatable. So I told him, you know what to do. So he got to the fridge and brought a 29C4, which is off-label treatment of known drug. Benralizumab, this drug is designed for asthma, eosinophilic asthma. So it's already available to us. And the only problem with giving off-label medication is to the signature of the chairperson of the 24C committee, off-label committee. Luckily, I have a personal relationship with the chairperson, which is me. So I signed myself and brought the drug from the fridge, and we gave it to the patient in urology. 3 weeks later, he called Aviv crying. He started passing urine. On January, after a few months, he came to the urology department, did a cystoscopy. He has normal surface of the bladder, normal volume and normal expansion and normal biopsy. They took up the nephrostome and he went home healthy. We currently have 5 patients with eosinophilic cystitis, and it's an over treatment. It was a mutilating treatment so far.
Wait, so AstraZeneca gave you the...
So he said, I told him, how long would it take you to get permission for this? He said that maybe 2 to 3 years. I told him it took me 2 seconds. So he said, you have the research. So since then we have like 15 novel diseases that were targeted with Benralizumab with a great success, like eosinophilic leukemia for an elderly patient, a Kimura syndrome, rare syndromes, even a young girl, 27-year-old with extremely rare disease, which is called eosinophilic vaginitis. She couldn't even sit down for the last 4 or 5 years.
Oh,
and after the first shot, I saw this lady came. She was like, wow, it's you. She's clear by now. And we have like, as I said, we have like 15, 16 novel diseases for this kind of therapy, which responds almost instantly.
I understand you're also doing some work with Harvard in the field of lupus?
Yes. One of my beautiful, wonderful physicians, a girl called Limor, is going to fellowship in Boston. We have a sister lab in Boston. It's a sister lab since it's my sister's lab. So she is, I like skewed her to conduct research with atopic dermatitis and lupus. She has a very, very interesting article, research about racial disparities, which mean that black and white have unique immune manifestation. Like black has much more severe and abundant lupus, SLE,
Okay.
than white. Black has more atopic dermatitis, more allergic rhinitis and asthma. They die more often from sepsis. Everybody was talking about demographic changes.
Right.
Actually, what we discovered that they have a unique immunological mechanism that was probably developed within ages that make black person more susceptible to die even from corona. For instance, in corona, black Americans died 4.5, 5 more death were more prevalent than white. And when you excluded demographics and health issues and stuff like this, you are still like 2.5 times more. And we found out that melanocytes, dark melanocytes, secrete less substance that inhibit immune cell in the skin. And now we are trying to block it. And we have a few medications that we can utilize. We're trying to block it to see if it's correct. We can fine-tune medication for 20% of American population, and then to the other 80, because we can reverse the treatment, we can enhance other. So I'm sending Limor to my sister. She promised she'll bring it back in 2 years. Otherwise, I'm going to the US and take her. And they have a collaboration with George Tsoukas. George Sokos is a chief editor of Clinical Immunology Journal. He's a leading lupus investigator. He's a good friend, and she's going to combine the two fields in both labs. So yes, we have some collaboration, which is very, very private.
Okay, got it. So talk to me a little bit about the work that you're doing, in terms of working with other departments, collaborating with other specialties here in the hospital. Are there other kinds of areas where you collaborate and then that helps to impact, the clinical care?
Telling my students that humility saves life. So we collaborate with anybody that asks. Lung, rheumatology, oncology, hematology, orthopedic, whoever asks, we were there. And we will ask for a collaborator in dermatology and ophthalmology. I'll give you an example which is quite far. Diabetic patients. Diabetic patients often have, not often, but in large number, has an allergic contact dermatitis to the patches of the skin of the pumps, the insulin pumps, or the sensors.
Makes sense.
And they needed to change brand or whatever, and usually it doesn't work, and they switch back to 4 injections a day, and which is far less
Convenient for sure.
convenient and not as good actually.
Oh, really?
Because you're doing it like pick insulin 4 times a day, and
As opposed to
this is a gradual and sensor related. So I told our diabetic doctor that send them over. We will try to help. We have an idea. I talked to one of my physicians, and we gave him prophylaxis local medication from three types of medications, and checked which is the better. And then we did a skin test with all the ingredient in the patch, and we found out that there is difference of ingredient between patches. So in 20% of the patient, when we switch patch to another manufacturer, it resolved the problem. And in 50 additional, like 70% altogether, 70%, the prophylactic application of the lotion almost completely solve the problem. So they can reuse 70% of them, can keep using the pumps or whatever device they're using, and worldwide it's a huge diabetic problem. So it was a phone call between friends, and yes, we can do it easily. Send them over, we'll help.
So how do you see the future then of clinical immunology? We talked about biologics and that's really the next big thing. But are there other areas that are evolving in, moving that personalized medicine further, or in any other capacity that you feel we should know about?
Actually, we have 2 major research that go on differently than the biologics. First one is an Israeli company called Nasus, which is not yet available in market for shares. So if it will bite,
I'll remember to write that down. Yeah.
intranasal dry powder adrenaline,
Okay.
which you use for resuscitation from anaphylactic shock.
Right.
And we have the EpiPen in the world, but in the world it means that we have the EpiPen in America, not in the real world. Like 80% of the world doesn't have EpiPen.
So people just stop.
Expensive. It's big. It is off-label. It is can be used after a year or so because it's water soluble. 70% of the people will not use it when they need it because it's a needle. And in like 30%, additional 30%, they will use it and then will take it out before it inject, and nothing will come in. So this is a dry powder EpiPen. I use it with my own hands on the experiment. It is amazing. It absorbs 4 to 5 times faster than intramuscular adrenaline. It's a tiny device. You only squeeze it to the nose and push. You don't need any collaboration. It's achieve peak value in the blood, the target peak value within 2 to 3 minutes.
And how long does it take with the injection?
Amazing. I provoked allergy in an allergic patient, and nasal allergy. put a drop of olive flowering in an allergic olive patient, and then injected and squeezed this bottle into its nose, and you saw that the monitor increased heart rate, and then he felt palpitation, and then the nostril opened. It was amazing. And now it's a tiny bottle. It costs like 2 shekels. I don't know, nothing. You can carry on 10 of them. It doesn't disintegrate, so it can last ages. You can bring it with buses to Eastern Africa, and it will be okay. It means billions, and God knows how many lives.
How long do you think until it actually does get on the market?
On the verge of being in the final steps. FDA almost approving it. We have a board that we're committing in the US, which are best friends there, and we have many friends in the US. And we're going to do today a board meeting with the US board.
Amazing. And you mentioned there were two, so what's the second?
The second one, it's a series of researchers. It started a few years back when he found the connection between psychiatric illnesses and allergy. I will do it short. We found out that in order to have PTSD, which everybody in the world has it currently,
certainly in Israel.
Yes, you need a repeated psychological hits.
Okay.
And then there is the one, the last straw, and you have PTSD or probable PTSD. And I came to a mother of one of our children we are treating with a solar urticaria, light. He can have anaphylaxis from light. The young boy.
Okay.
And we offered him a new medication, and it was fine. It's a different story. It was already published a long time ago. Mm-hmm. And she's an expert at PTSD. So I told her the boy has something like anaphylactic to light, So she said after 2 weeks, no, the child is fine, but there's nothing in the literature for PTSD post-anaphylaxis. I told her it's going to be because you're suffocating to death. You make PTSD from bulliness in school. So suffocation. So I can prove it to you. I took Hymenoptera bee sting allergy patient that had anaphylactic shock and compare it to bee sting anaphylactic that has large local reaction. Uh-huh. And we check for probable PTSD. Probable PTSD it's about 33 points. It's highly likely. And we found out that that after anaphylaxis they have like 60 to 70% to have probable PTSD, which is a huge number. But if you reverse it, you see that repeated hits of psychiatric or issues, stressful issues, could enhance the probability that you have anaphylaxis. Not because
and vice versa.
You think it's a statistical bullshit. I didn't find it. And however, when you rethink it, stressed person has harder to control asthma. They have harder atopic dermatitis. They have more severe and persistent hives, urticaria. It might be something there. So I went out to the literature and found out an article about rats. They made them allergic to ovalbumin, egg.
Okay.
And then they had an aerosol spray of ovalbumin and large noise and pictures, a large noise and lights.
Okay.
And they had an anaphylactic shock. And then they re-exposed them to ovalbumin and large noise and they have an anaphylactic. And then again, and the fourth time they split them into two. One box has a aerosol of ovalbumin, of egg, and light and sounds, and the other box has an aerosol of PBS, which is saline water, and sounds and lights, and both good at anaphylaxis, both of them. So they said that it is a Pavlovian reaction. But then I got into the article and so they are describing the rats. The rats were sneezing, scratching, gasping for air. So they had an anaphylactic shock. Rat cannot mimic anaphylactic shock. So I went to the lab, to the corridor, and went to Professor Flowers in psychiatry. Told him, I have weird things about PTSD and anaphylaxis. He said, "Wow, I just recently published a paper about PTSD in young adults that were exposed to terror attack when they were children. Half of them, 20 had PTSD, 20 had not developed PTSD, and we checked for immune resting profile, which is like spray and pray, and whatever you hit, it's fine." Okay. And we had some elevation, non-specific elevation. Would you like me to send you the article? I said, yes. Yeah. Send me the article, but there was one protein that was highly more prevalent statistically than other, which was IL-4. Right. The same protein that we talked about earlier.
Oh, okay.
It is the hallmark of the immune allergic response. So chronic stress elevate IL-4 and make the allergy more severe.
So basically, it's like it's chicken and egg. Either you have a severe allergy, you can lead to PTSD. Yes. PTSD can lead to allergy.
Every disease, every biochemical reaction has two ways. Water, H2O, 2H plus, and OH means everything is going both ways. So we started checking it and finding it with food allergy. Either it's real food allergy or it's not real food allergy. The prevalence for you to have PTSD, anxiety, depression, eating disorder, sleeping disorder is far more prevalent than those who doesn't have label of food allergy, which means it doesn't really have to be real allergy. The stress itself could destroy everything. We have another work on half of the population in Israel about toddlers 0 to 3 years old that are labeled as anaphylaxis to food. 90% of them are not real. It's just labeled. And they have 500% more overall psychiatric illness or food allergies or a sleeping disorder when they are adults. It doesn't matter if it's real or not. So now we are trying to fine-tune the mechanism, the molecular mechanism of these relationships, which is very interesting and could help millions of children worldwide.
Incredible. Well, Dr. Tal, thank you so much for being here today. I think everybody is going to benefit, all of our viewers, from this analysis.
Thank you very much. It was fun.
Yeah, for me too.